Okay, so we should be recording now. It says that we are. So the first part, so we've introduced each other. We've I can see already Amanda has put the photo up on our document there. And we've talked about the philosophy, we've talked about, advice from previous cohorts that you should definitely concentrate on pre-work. And the philosophy of teaching and learning, which is that we very much do active learning. So the first thing that's going to happen is I'm going to briefly revise ocular melanomas. I'm going to use the document that is linked to in the course run sheet. Okay. And I'm about to attempt to Google Doc. Share screen. Here we go. I'm going to share the screen. Okay, so hopefully you will be able now to see the shared screen. And I'm going to use slideshow. So it becomes full screen. Okay, good.
Looks good.
I'm going to briefly run through some things. So often you will be asked about melanomas in the exam, particularly in the slide part, but also in the written part. So when it asks about the pathology of melanoma, you've got to think of a structure in which to discuss that. Okay. So often they talk about macroscopic and microscopic appearances when they ask you to talk about the pathology. So the macroscopic appearances can be what you see down your slit lamp, okay? But also it's what we see at cut up, right? So in answering macroscopic, I'm sure you've all seen melanomas, do like a one-liner on the slit lamp and then describe what you see down at cut up. Now, many of you will not have had the opportunity to go to cut up. We're friendly people. We love people coming to the lab, pathologists. So next time you take out a melanoma, ask if you can come and watch it be cut up. It's really helpful. So these are what we often see at cut up. So we cut it. I don't have my. Can you see me as well?
Oh, put it right in front of your face, Diane. Yeah. Okay.
Right.
You've got your spare eyeball.
Yeah. So we've got the eyeball. We make a cut so that the tumor is sitting at the bottom. So we get a transpupillary kind of cut, and we cut 1 millimeter in from the edge of the cornea and go back to 2 millimeters either side of the optic nerve. That's how we cut up the tumor, and you get this. So we'll describe it either as dome-shaped, mushroom-shaped. We'll describe where it is, in particular its distance from the ciliary body and the optic nerve. And we will, of course, measure its base and its height. So these are typical features that we would describe when we're doing gross appearances. We would also look at the outside of the eye and notice any extension. Here we've got it extending probably along a little blood vessel. We would notice any extraocular extension, any pigmentation of the sclera, and of course, this is the microscopic correlate. Now, this seems really obvious, but if you mention those things, you will get points, okay? So what does a mushroom shape mean? It means it's extended through Bruch's membrane. Bruch's membrane is thin, but tough. And once it has gone through, it forms this characteristic mushroom shape and is then able to spread directly into the retina. All right, number 2, the calendar classification. I'm sure that you all know the calendar classification. So the calendar classification describes the type of cells that we see, but the prognostic feature depends, the prognosis depends on the percentage of each of the cell types. So we usually describe it as either spindle-shaped, so spindle, if either of the spindle types are present in over 90% of the tumor. Epithelioid, if 90% of the tumor is epithelioid, okay, and then mixed. if it falls in between each of the 90% things. And
Diane, could you explain what epithelioid means?
Absolutely, because they're not epithelial cells, are they? I mean, it seems crazy. They're not epithelial cells, but they have some of the characteristics of epithelial cells, which is copious pink cytoplasm and large round nuclei with nucleoli. Okay, so these are the epithelioid cells, and this picture shows it nicely, where you can see the epithelioid cell versus the spindle cells. They're usually quite obvious, and we'll show some tumors to you during this course that will help you to actually be confident about making the distinction. All right, so in the chat, I want you to tell me what cell type this is. Is it spindle or epithelioid? Amanda, can you monitor the chat for me?
I am. Everybody is saying spindle.
Perfect. And this one?
Ooh, that's a bit trickier, isn't it?
Isn't it?
Okay, team, go. So we're going to have spindle. Everybody's still spindled.
Perfect.
Spindle
You guys
B.
are good. And this
What's
one?
the difference between A and B? Spindle B is what people said.
Yeah, so this used to be called spindle A. Spindle A, all gone now, because it has the nuclear grooves and no nucleoli. So they're just different morphologies of spindle cells. Yeah. And then these ones.
Ooh, okay. They look quite different. And epithelioid.
Great. Yes. Okay, so let's flash between them. Spindle, epithelioid. Great. And this one will be.
And people are saying mixed. Yes.
Great. Okay. So how do pathologists report uveal melanoma? You will see that lots of pathology reports these days come out as long lists. And okay. And we report them according to tumor protocols. I like this, the College of American Pathologists tumor protocol. You'll find a link to it in the slides.
Sorry, Diane, there's a question here of how you tell the difference between epithelioid and giant cells.
All right, we don't, because it's not in the classification.
Doesn't
giant
matter.
cells will never be a predominant feature, and if they are, we call them epithelioid. All right. Okay. So these are the most important histologic features that you need to draw out of the CAP protocol. So far we've covered what to say when we want the macroscopic, the difference between epithelioid and spindle cell, and now we're up to what are the most important prognostic features that appear in a pathologist's report. The tumor cell type, the size of the tumor, basal dimension, extraocular extension, tumor location, and then the complexity of the extravascular matrix patterns, and then some IHC. So let's have a look at some of those. All right. So some of them are really obvious, but people are always worried about these extravascular matrix patterns. When you're looking at pictures, always look very, very carefully at the scleral nerves and veins. And remember that macrophages will pick up pigment, okay? And they will transfer it parallel to the nerves and the veins. So you've got to look for the abnormal nuclei to actually determine whether or not it's invasive. Similarly, the trabecular meshwork can have pigment in it, but you've actually got to see the cells in it in order to decide the cells in there. Yeah, look for ciliary body invasion. Where does the ciliary body begin and end? Who can tell me? Where does it go? How do you know you've reached the posterior aspect of the ciliary body?
Type it in the chat. Oris errata.
Yeah, okay. Okay, yep. And then the iris neovascularization, we're going to spend quite a bit of time on our benign day looking at how you detect whether there's neovascularization, and then look at the optic nerves and meninges. In particular, we want to know whether it's pre-laminar or post-laminar. Okay, so what are these extracellular matrix patterns? There are these things here. So Amanda and I went to a lovely workshop in June together where we did some botanical art together, and we learned to draw the vascular patterns in leaves, okay? And so we were doing that, and it occurred to me that the vascular patterns in leaves are just like this here, right? Imagine you're looking at leaf veins, all right? So these are the loops that form in these extra vascular matrix patterns. Okay, so this is what we're talking about.
And they close the loops. So a lot of leaves, the things go out to the edge, but think of something like silver beet, where it's kind of like rounded veins, bubbly bits. I've got some silver beet in the vegetable drawer. I should bring it along.
Yeah. Okay. Now we know that a lot of the outcomes of melanomas are due to genetic abnormalities. So if you're discussing prognostic factors, go through the histology, go through the macro, go through the histology, but then address the genetics. So this is now old news that chromosome 3 monosomy is bad, gain of 6p is good, and they're usually mutually exclusive, right? An 8q can, is a bad prognostic factor if the chromosome 3 is normal, but mostly now we don't do FISH. What we do instead is immunohistochemistry for BAP1 and PRAME. So I'm going to spend a little bit of time talking about that after the FISH. Some people get confused about FISH. All it is painting the chromosomes. Okay, so we paint the chromosomes different colors so that we can count them. Probes are used that attach to the DNA that have a fluoro thing attached to them, right? And here we've got a monosomy 3. And what would happen is in these cells, the 3 would be labeled green and another chromosome would be labeled, say, 4 red. And you can see that there's twice as many reds as greens. So we know that there's monosomy 3. Okay, I don't think we need to go through that. You all know that melanomas are divided into class 1 and class 2 based on the presence or absence of chromosome 3. And then depending if it's got normal chromosome 3, then depending on whether chromosome 6 or 8 is present, it goes into intermediate. But loss of chromosome 3 is always high. But what we actually do now is use BAP1 and PRAME. Why do we do that? That's because it's actually much faster. We can give you an answer to BAP1 and PRAME in a couple of days rather than FISH. That takes longer. And also, it actually gives more information than doing the FISH. So that's the most important thing. It gives you better prognostic groups. So you can see if we do these immunohistochemistries, BAP1 and PRAME, it divides into 4 groups. One where we have intact BAP1 and no gain of PRAME. So basically BAP1 and PRAME stay normally. We've got a really bad group where BAP1 and PRAME stay abnormally. And then we've got the combo where we've got BAP1 normal, PRAME abnormal. It is slightly confusing, and I'll come to my pictures in a moment. So so metastasis-free survival and disease-free survival, BAP1 and PRAME are really great. It is slightly confusing because BAP1 is a marker. It's present on chromosome 3, and it is normally present in all cells, right? So usually we say BAP1 is retained, and you'll see BAP1 positive. We don't use positive and negative, really. It's confusing. So we say BAP1 is retained, and that means the tumor is staining like normal, and it puts it automatically into the beta 2 groups. All right. So if BAP1 is lost, this is chromosome 3 lost, badness. All right. And then we have PRAME, and unfortunately PRAME stains the other way. so that normally it is absent.
What's PRAME? It's an acronym, and that helps
It
us
is an
remember it.
acronym,
Its
right?
function. Yes.
I've forgotten. What is it, Amanda?
It's preferentially expressed in melanoma. So it's a tumor marker.
Yeah, preferential. Yeah, right. So with PRAME, if PRAME is abnormal, it's positive. But when we write reports, we'll try and not use positive and negative. We'll try and use BAP1 retained, normal, PRAME absent, normal. Okay, words like that. All right, so that brings me to the end of this. I'll just stop sharing. So that brings me to the end of my very brief chat about melanomas. And now I want you guys to please ask me questions about stuff that you didn't understand.
You can type in chat or just put up your hand in the Zoom window and we'll call on you, just so that you don't talk over each other. Okay, Bridget's got a question.
Can I ask just on your PRAME immuno, because I know in my laboratory we do a lot of skin stuff, and our PRAME for skin isn't as great. You know, we're finding it's not as great as they initially suggested it would be. Are you finding in eyes that it works really well, or is it a bit more difficult to interpret?
I've not had a problem with PRAME, actually. I often use the PRAME red.
Similarly, we use PRAME red as well.
Yeah,
a red chromogen. The reason we use a red chromogen is because all immunohistochemistry is brown chromogen. It's difficult to tell the difference between chromogen and melanin granules because they're both brown.
Yeah. So we often we use a red chromogen for SOX10. Yeah.
Yes.
Yeah.
So Diane, you were talking about markers in melanoma, and Bridget just mentioned SOX10, which is a melanoma marker. Do you ever stain your uveal melanomas for a melanoma marker? Is that necessary?
No, because I know they're melanomas. No, because you just look at them, they've got pigment in them. What else could they be? We only use melanoma markers if we don't know what the histogenesis of a tumor is.
Okay, so you don't need a melanoma marker then. Okay, because it's making melanin.
Marker. No.
Okay, so good to know what's not useful. So the PRAME and the BAP, does that help you tell if it's a melanoma or not?
It doesn't. They're just prognostic markers.
Okay, so there's a difference between a classification of cell type and a prognostic marker, immunohistochemistry. Okay, good to know.
Right.
I'm just having a look at any questions. Okay, here's a question from Michael. In the exam, when they ask about prognostic markers, would we be expected to answer with immunohistochemistry, BAP and PRAME rather than talking about fish for monosomy 36 and 368?
Yeah, so if this was a whole question, then I would probably start with the IHC and then say that fish used to be used, but is no longer used, but can be used in some centres.
Yes. I mean, the 368 is not incorrect, and perhaps some centres might not have PRAME marker, for example.
Yeah.
They're all correct answers, all of those.
Yeah.
And Sukapriyan is asking the ECM vascular patterns were different types discussed, and which is bad or good. So are there different types of extracellular matrix pattern, or is it just present or absent, Diane?
So usually I report it as present or absent. And to be present, it has to have at least a minimum of 3 closed loops.
And like a circle shape, just like this, doesn't count. Okay, good.
Great. It looks like we're on to our first slides now. So what's going to happen now is I want you to all go to the course run sheet, and then you'll see after the ocular melanomas talk, there's a 5-minute break. We aren't going to do that because we're all so relaxed and fresh. But what we're going to do is we're going to go to do some uveal melanoma slides. So we're going to do one slide at a time. Okay, so what's going to happen is I'm now going to open the breakout rooms, and I'm going to put you in breakout rooms in pairs, hopefully with a tutor. And you are going to look at the first slide. So that's the first slide with the little picture from Leeds. So before I put you in breakout rooms, I want you to please click on that slide to make sure that you can open it.
Perhaps, Diane, we should just have a bit of background and housekeeping rules about how to interact in breakout rooms using pair programming. So we're using a technique which is a social and collaborative learning technique. So this means that you learn together with a peer, one of your peers. You are not to expect a tutor to tell you everything. This is when you are sharing information with a peer, P-E-E-R. So in the room, one of you chooses to be the navigator and the other one chooses to be the driver. It's like a motorsport rally. So one of you will share the screen and you are the driver, and you share the screen with the other person who's the navigator. The navigator does the talking. The navigator has the textbook open. The driver basically zip, okay? And the navigator tells them, go over to the optic nerve, go up higher power, go at lower power. The navigator is navigating and the driver is driving the slide. Why do we do that? It breaks up the cognitive load and you both learn at the same time much faster. When we do the next slide, you swap roles. So you'll be with a different partner. So this is promiscuous, and you'll be a different partner and you swap roles. So you all get a chance at being a navigator and a driver. Okay. One of the big mistakes is that once the driver has the mouse, they start talking and the navigator shrinks into insignificance. We don't want that to happen. And because there's there's 4 tutors, we'll be able to drop into the rooms or be in a room with you. We're not going to give you the answer, we'll give you guidance, such as we'll say, you can ask us questions, you know, what's this or what's this? And then we'll guide you to find out the answer yourself.
Okay. Yeah. So have you all been able to open the slide? That's good. Okay. So I'm going to put you in pairs in rooms, and you'll see on the schedule there that you've got some questions that you want to, that we have to answer. We want to know what tissue is normal, so identify normal tissue. I want you to look at the tumour. I want you to describe its features at low power, high power, and prognostic features, and then think, what pathology investigations would you do? Okay, Amanda, you're in charge of room 1 and 2.
Okay.
Archana, you're in charge of room 3. Bridget, you're in charge of room 5, and I'm in charge of rooms 6 and 4. Okay. I'll open the rooms and you'll be assigned to the room. The first thing you'll need to decide is who's going to drive and who's going to do the academic work. Okay, Sahar, hopefully you will be able to join, I think you're room 4. Is there a problem? Don't seem to be able to join. Okay. I'll just move you to. Did you see? You can only see me. Yeah, you should have got an invitation to a room. No, okay, we'll try again. Okay. So we're just waiting for everyone else to come out of the breakout rooms. And
Hey, welcome back, everybody.
hey, yes, everyone's here. So my groups did really well. They applied the structure, so that was excellent. We're going to go through the slides, but the first thing I'd like you to do, if you've got any questions, just pop them in the chat, or anything you'd like us to show you, particularly in our group share.
And we've got a new participant, Jonathan has.
Jonathan, that's right. Jonathan, you were going to be slightly late, but welcome, Jonathan.
Welcome.
Where are you from, Jonathan?
Queensland.
Cool.
Right.
Yeah, Queensland. Here on the Gold Coast right now. So
can you
right
right click on your face square and rename yourself? Just put hyphen where you're calling in from, just like everybody else.
Okay. So Karina said, can you go through mitotic features? So mitoses are pretty hard to see on digital slides. And I would personally recommend that if you are doing it in a written question, then yes, you might want to talk about the mitotic rate. But I think that if you are looking at pictures, you won't be able to determine the mitotic rate at all. So just say mitoses not able to be counted on these pictures. Yeah. Okay, Amanda, would you like to share and I'll ask where we're going and stuff?
Okay, I'll be driver. So in some of my groups, there was a bit of confusion between the roles of the driver and the navigator. So I'm driving this slide and I'm going to screen share it. Screen share, slide viewer, share. Okay, does that look all right to everyone? Yeah.
Yeah, that's great. Okay, so at low power, what I can see is the globe, and located close to the ciliary body in the inferior part of the globe is a tumor which has a melanotic part and an amelanotic part. So this indicates that there's there's two clones growing, you know. So the first thing I've got to do is identify normal tissue. Amanda, can we have a look at the front of the eye to see how normal that is?
Sure. Starting here.
Yeah. Okay, so the cornea looks a bit edematous actually. There's a bit of loss of lifting, but the epithelium looks okay and desmos looks okay, and there's a normal number of endothelial cells. But I do notice that the front of the iris is very flat, and this is a sign of neovascularization. Can we see any neovascularization? I wonder.
Let's just drive along here.
It can be slightly tricky to see, and Amanda's driving around looking for neovascularization.
That'd only be capillary-sized vessels. Oh, Diane, what about these and big vessels? What about these ones?
Yeah, those are normal iris vessels because they've got that cuff around them.
Okay, so that's not neovascularization then. I'm just looking along this very anterior surface to see if I can see some lumens with red blood cells in them. What about that one, Diane?
Could you point it to me?
No,
that's a big one. That's got the cuff around it as well. So we can't see any, but we suspect it because it's flat. And then I noticed that the iris, there was pigment on the lens as well. So the iris has probably been adhering to the lens, hasn't it? At some point. And then I noticed that the lens isn't quite right either, because we've got separation of the nucleus and the cortex, and just peripherally there seems to be some breakdown. There's some globule formation, so we've got early cataract formation, probably. Well, it's not too bad actually.
Not too bad.
Not too bad. So the lens is, is that a bit of calcification? Anyway, so the lens is probably normal. And the other thing at low power is the retina on the other side looks normal, doesn't it? And the optic nerve looks normal.
Retina, optic nerve, little bit of optic nerve. Okay, 1, 2, 3 layers of nuclei.
Yeah, so that's all good. There's a subretinal exudate, and at low power, I can't see anything going through the sclera. So, Amanda, can you drive to the non-melanotic bit? And I'm choosing the non-melanotic bit because it's much easier to see what's going on. And at this medium power, the thing that strikes me is the vascular arcades. So Amanda, can you run your mouse around some vascular arcades?
I can see really good back-to-back vascular arcades, 1,
Yeah.
2, 3, back-to-back there,
Numerous ones.
making complete loops. So extra,
So,
so that's capillary loop matrix positive or present. So is that a good or a poor? Is that good or bad, Diane?
it's bad. It's bad.
It's a bad prognostic factor. Okay.
It is. Yeah.
Mhm.
So let's go a bit closer, can we, Amanda, and look at the cell type? Right, so I can see lots of spindle cells there. They predominate, but I can also see some epithelioid cells. Yeah, so cells that have copious cytoplasm. So there's a little group of them down the bottom of the screen now.
Yeah,
there's
probably some down here as well.
And there seems to be slightly, about, I don't know, about 20% epithelioid. So I'd say this was mixed.
Yeah, there's some more down here. What's the cutoff between one type and another type and mixed?
It is 10%.
So we need 10%. So it's mainly spindled. So we need more than 10% epithelioid to call it mixed.
Yeah.
Okay.
And I think we've got that. Great. Okay. So let's see if there's any scleral invasion now.
Okay. Now in my group, we saw some pigment.
Yeah.
Here we go. There's a little pigmenty stuff here. Just wait for the pixels to resolve. Go down one. So here we go. It's coming. Here we go. This area here is pigment.
Yeah, there is pigment, but there's no cells going in. It's just pigment leaking in, isn't there? It's a bit hard to see in places, but probably just pigment.
It would have to be a cell that looks like that. So if I'm not sure, I do compare and contrast. I compare to a malignant cell, and then I go down here. I don't see those cell nuclei.
No. And can we shoot across to the ciliary body as well?
Okay, let's go have a look over here. So ciliary body. What part would you like to look at?
So that bit there, just where we've got those, like, we can see the start of the oris serrata and the ciliary body, but does it really invade the ciliary body, or is it just like pigmented macrophages like abutting against it and starting to infiltrate? That's the question to ask. The bit that's at the bottom left.
Down here.
Yeah.
There we go. Smooth muscle.
Yeah. So is it in the smooth muscle is the question. And we can see that there are pigmented cells in the smooth muscle. So then we've got to ask, are those malignant cells or are those macrophages?
Okay,
Ooh,
that's my closer. There we go.
Actually, when I was looking at it with one group, I thought that they were macrophages, but looking at that now, I can see they've got big nucleoli.
Big nucleoli.
So in fact, there is invasion of the ciliary body. Yeah.
Yeah.
Yeah. Sometimes you just have to get real close and have a look at the cell type. Okay. Yeah. So we've got a melanoma that's approximately, I guess its base is about 10 millimeters, its height's about 16 millimeters. It's mixed type, there's invasion of the ciliary body, there's no invasion of the sclera, there's possible neovascularization. I've got to look at the trabecular meshwork, but it appears to be not involved.
It's down here.
Yeah.
There's pigment.
There's pigment, that's right. I don't think there's cells in it.
We're not
all right.
fooled.
So is there anything else that you noticed, Amanda, that you think we should talk about?
My group did notice a difference. Why is one part not the same color as the other part? Why is that? These three, there's super dark, medium dark, and hardly any pigment.
Yeah, so these are different clones that are growing in the tumor, and one of them's not pigmented.
Yeah,
it's useful when it's not pigmented because we can see the cells better. Okay,
that's our trick.
Work out gross. Based on we. All right. So Andrew's asking, how do you work out the gross size based off eyeballing it? So I presume that the eye is 25 millimeters long, from front to back, and I just kind of divide up approximately the size of the base. Yeah.
There's also a little scale marker down the bottom here. See, 1 millimeter.
Oh,
Tells
yeah,
you
there we go.
so you can do
Yeah, I didn't notice that.
4,
But there we are. Yeah,
5.5, something like that. Basal diameter.
yeah.
Okay. Any other questions? See, I can't get both of those things on my screen at once, so Diane has to look at those. So,
Okay, should we, does anyone else have questions? Should we move on to number 2?
yep. And I'll stop share.
Okay, that's great. I'm going to open the breakout rooms again. I'm going to keep you with your partners, except I'm going to move Archana to room 1. And I'm going to move Bridget to room 2. So that Amanda, you get rooms 3 and 4, and I get rooms 5 and 6.
Okay, fine.
Okay.
Okay. Hello, Diane.
I seem to be sharing the wrong thing. You're screen sharing. Here we go.
Yeah, you're sharing the right thing, which is good.
That's great.
Shall I navigate you? Any questions in the chat so far from that one? And we can.
Diane, won't you just go through the vascular pattern again? Just show some more of the vascular pattern on this.
Sure. So remember, it's going to be easier to see in the less pigmented bits. And it's easy to see from medium power.
Medium power. Mm.
Yeah. So as we look around, we can see the pigments kind of collected in loops.
I think there was quite a good bit area, sort of more posteriorly in the not so pigmented areas where I found better pattern over here. Yeah. Looked rather loopy to me.
Right.
It's jumping around all over the place.
I know. So I'm trying to. I should let you guide me. Go on, guide me.
Okay, so like medium power there. Okay, so I can see an indication. It looks very nodular to me, like there are little balls back to back almost. So I think at this power, I think there is the extracellular loop pattern present. What do you think, Diane?
I think there is. Yeah.
Yep. Okay.
Yeah. Okay.
Okay, so starting at low power, we have, if we can get the whole thing into the frame of view, we have a nucleated globe. It's not the pupil optic nerve section, it's a para-axial section. And at this power, I can see the cornea is intact, the iris is intact. Now, there was some questions about, now the little fragments of pink stuff behind posterior to the iris. Now, what do they could be? They, you know, lenses are normally that nice oval flying saucer shape, but what's this?
Yeah, so it's got, it looks a bit like lens because it's got the basement membrane and then it's got the cells underneath it and it's got that kind of lens structure, but there's no lens. So we've got bits of lens.
Bits of lens. So it's been all fragmented up. Yeah.
Fragmented lens, yeah.
And that often happens, doesn't it, when we're cutting it and the technical staff are cutting it. So natural parts of natural lens. And then as I move posteriorly, I can see in the posterior globe, there is a tumor. It's about, I don't know, 10 millimeters in basal diameter and maybe even 10 millimeters tall. So it's on the large size. And then posterior, and it appears to be arising from the choroid. It seems to involve the ciliary body all the way up to the root of the iris. I'd have to look higher power later to see if it actually involves the iris. But just at low power, then I can see posterior, there is a, looks like subretinal exudate. And the tumor doesn't seem to involve the origin of the optic nerve because we don't have it in this section. So those are my lower power observations. Now, my medium power, I've established these vascular loop pattern. I want to know the cell type, is it epithelioid or spindled? So can we have a look on a not so pigmented area to determine cell type, please? Oh, well, they look epithelioid to me. Is there anything else? Let's pick another area, make sure that we're not missing. I can see mitoses too. There were 3 or 4
I saw a couple of mitoses. This is,
yeah.
Well, the mitoses look kind of nondescript, really.
Yeah, there's one there and there's one adjacent to it. Anyway, I thought there was epithelioid in the field that I examined.
Yeah.
The other prognostic factors. The shape, it was dome shaped, so not mushroom shaped. So I think Brooks membrane is probably intact, but I would have to look closer. But I'm really interested to have a look next at the anterior ciliary body and the root of the iris. Okay, so even at low power, I can see there are cells in the ciliary body. I want to make sure that they're actually tumor cells. Do they have those ugly looking? Yes, they've got the big nuclei and the big nucleoli. So there is melanoma in the ciliary body. And then as we move a little more towards the angle, I can see this is the iris on the top there. not quite tumor cells in the iris, I don't think. But
No, I don't think there is either. I think it just
no.
shaves off.
And then up here we've got this is the angle, and then there's the trabecular meshwork in the canal of Schlemm, and then there's a pile of little dark cells that are around the canal of Schlemm, but they don't quite look the same as the larger melanoma cells to me. These little dark fellows there, I thought they were lymphocytes. What do you think, Diane?
Yeah, I think they're lymphocytes as well, but I'm very worried about these cells here.
These ones, you see how they're different? They're larger and they have more paler cytoplasm. So not all things with a blue nucleus are a melanoma cell. So
I think
yeah,
I thought this was in the trabecular meshwork.
Those ones there, whereas can you point out the lymphocytes again? Where's the lymphocytes? Those ones there, they're lymphocytes. Okay.
And some macrophages with pigment, but yeah.
Okay, so we've involved a number of adjacent structures. And what else?
We found some nice neovascularization.
Yes, have a look at that.
There. So the front of the iris is kind of flat in places, you know. It's got some normal rugation peripherally, but then it flattens out. And then just here you can see little vessels. See, those are capillaries.
Possibly. Oh, even maybe towards the right side, it looks like there was some extravasated capillaries. There, that one, there. Capillaries with red cells on them. Although retinoblastomas
I like that one.
usually have more iris neovascularization than melanomas, don't they? Yeah. Oh no, that back there, that was quite good.
That one.
Quite good iris neovascularization.
Yeah. Okay. So that was that. So so I think you all did really well. And
there's one question. We couldn't see the retina over the exudate. Could you please point it out?
All right.
Retina over the exudate. Ah, right.
So it's been lost, really.
Yeah.
Torn away.
It's really flimsy when you cut it.
It's pretty flimsy. You can kind of.
And was there scleral invasion? Well, there's invasion of the trabecular meshwork.
But we didn't think that there was scleral invasion, no.
At the base of the tumor.
There's still quite a good line there. Yeah. Thought that was all right.
Okay. Yeah. So this falls into the large size. Yeah.
Oh, some more chats. Eosinophilic material. All right. So this stuff here.
Oh, yes. The pink stuff in the holes. Let's go a little closer. What are the shapes of the blobs?
You're really close.
Yeah. They're cells, aren't they? They're red cells without nuclei. So it's blood.
Blood, yeah.
Hemorrhage. It's fresh. Yeah, it probably came out during the time that you were enucleating the globe. Yeah, it's you know, surgical trauma. Okay, cool.
All right.
All right.
Sharing. I think it's time for a short break.
I think you're right. Come back at.
We're running behind, but we often do that.
Yeah.
So half past, Amanda, for your talk on retinoblastoma and other pediatric tumors. Okay. All right, team. So I'm going to stop the recording because it's good to break it into sections. And you've all got to try and remind me to start recording again.
Yes. And it's important to get up off your chair, move around, go and have a cup of tea because that's what I'm going to do.